Hello students, my name is G. Nikita, M. Pharmacy, Assistant Professor in Department of Pharmaceutical Chemistry. I will deal the Medicinal Chemistry 2 subject for B Pharmacy 3rd year's first semester. So today we are going to discuss about anti-diabetic agent. It is the 5th unit. So in this we will discuss that introduction means what is the diabetes and what are the types of the diabetes mellitus and what is the insulin and what are the types and preparations of the insulin and what is the oral hypoglycemic agents and the classification, what are the drugs used in the treatment of the anti-diabetic agent, mechanism of action, structure, synthesis, structural activity relationship, adverse drug reactions, and uses. So let's, before discussing about what is the anti-diabetic agents, let's discuss about what is the diabetes. So diabetes is defined as a heterogeneous metabolic syndrome which is characterized by the chronic hyperglycemia and glycosuria, negative balance, hyperlipidemia. So it is the most commonly occurring disorder which affects the each and every cell of the human body. It results either due to the insufficient insulin production, inability of the body to utilize the insulin produced and increase the synthesis of the glucose in the body. So what is the diabetes mellitus means? It is a common type of the disorder can able to see in any people. So nowadays we can able to see this disease in not only in the elder means old age people but also seen in the young age people, and by birth also the some of the children are suffering with the diabetes. It may be the due to of the insufficient insulin production or the body cannot able to utilize the insulin. So what are the symptoms of the diabetes mellitus? Like blurred vision means can't able to see properly, frequent urination, always they will feel hungry, sudden weight gain, always they will feel thirsty. So if they will get any of the wound means it will take most amount of the time to heal the wound, and also the tingling in hands and the feet. So next to see what are the types of the diabetes mellitus. There are two types, type 1 and type 2. Type 1 is the insulin dependent and type 2 is the non-insulin dependent. So type 1 is also known as insulin dependent diabetes mellitus. So in shortcut IDDM. So this type of insulin mainly occurs due to the destruction of the insulin which is secreted by the pancreatic beta cells of isolates of Langerhans. So mainly the insulin will be secreted in the pancreas of the beta cells. So the onset of the symptom is rapid in the type 1. So in the type 1 again it is subdivided into type 1A, 1B. So type 1A and 1B. This comes under the types of the type 1 diabetes mellitus. Let's discuss about what is the type 1A. So this type of the diabetes mellitus, it mainly develops due to the autoimmune T cells. So which is mediated destruction of the insulin secreting beta cells. So in this case what will happen means this cells, T cells mediated destruction of the insulin secreting beta cells will be occur. So the beta cells will get distracted and almost 90% of the patient diagnosis with this type of the diabetes. So most of the people will suffer from this type 1A type of diabetes. Next type 1B. So this type of the diabetes is yet to establish. It is characterized by the deficiency of the insulin with a tendency to develop ketosis. So here what will happen means the deficiency of the insulin will be occurred, but in the type 1A here destruction will be occurred. Next type 2, diabetes mellitus is also known as non-insulin dependent diabetes mellitus. So this type, it occurs due to the relative insulin deficiency. So it occurs because of the insulin deficiency, and onset of symptom is low and less marked than type 1 diabetes mellitus. So this disease usually progresses to such an extent that it requires external supply of the insulin in order to maintain the blood glucose level. So in this case, what will happen means, the externally we have to take the insulin into our body in the type 2 diabetes mellitus. So these are the types of the diabetes mellitus, that is type 1 is also known as insulin diabetes mellitus. In this type, 1A and 1B has been occurred. So this occurs because of the maybe destruction or the deficiency of the insulin in the body. Next, type 2 is known as non-insulin dependent diabetes mellitus. It occurs because of the insulin deficiency will be formed in our body. So next, let's see what is the difference between type 1 and the type 2 diabetes mellitus. So here we can see the differences, the type 1 and the type 2. So is also known as type 1 is also known as insulin dependent diabetes mellitus. Type 2 is also known as non-insulin dependent diabetes mellitus. So what are the characteristic features here? Increased insulin secretion. I said no, that in the type 1 diabetes mellitus, the so pancreas cannot able to secrete the insulin. But in type 2 diabetes mellitus, what will happen means increase the level of the secretion. So what types of symptoms we can see in the diabetes mellitus is polyuria, polyphagia and polydysplasia, fatigue, sudden weight loss, weakness and impaired growth, and poor wound healing, infection. And these are some of the symptoms we can see in the type 1 diabetes mellitus. In type 2, polyuria, polydipsia and weight loss, poor wound healing, dry skin, itching and blurred vision, twinkling or numbness in the hands. So these are the symptoms we can see in the type 2 diabetes mellitus. So how we can provide the treatment means, for the type 1 we can take through the insulin injection, and for the type 2 through the oral hypoglycemic agents, means by using the tablet. So this is the main difference between the type 1 and the type 2, that is it means in the type 1 what will happen means the insulin secretion will be decreased, but in type 2 diabetes it will be increases the secretion. So in order to maintain the insulin secretion in the diabetes type 1, we have to take the insulin through the injection form. But in the type 2, we have to control the secretion. So here we are taking the oral hyperglycemic agents, means the tablets are taken through the oral route. Next, let's see what is the insulin. So insulin, it is the hormone which is produced in the beta cells of the isolates of Langerhans in the pancreas. So this insulin is mainly produced in the pancreas of the beta cells of the isolates of Langerhans. This already we have learned in the first year of the anatomy, right? So where the insulin is produced means mainly in the part of the pancreas. So it will regulate the blood glucose level and various anabolic activities such as lipid synthesis and glycogenesis. So first, the insulin was discovered by the person, that is Frederick Banting and Charles Best. So these are the two persons, that is, see here, Frederick Banting and Charles Best. These are the two persons who have discovered the insulin in the year 1980s. So let's see the structure. So this is the structure of the insulin. It contains the chain A and the chain B. And chain A contains the 21 amino acids and chain B contains the 30 amino acids. See here, 21 in chain A and 30 in chain B amino acids. So it is a combination of the amino acids. The structure of the insulin contains the combination of the amino acids. Its molecular weight is 6000 daltons. and it is the combination, it consists of two amino acid chains. See here, chain A and the chain B. So which is connected by the bisulfate. See here, two sulfur atoms are there. Here one and two sulfur atoms are there, which acts as the bridge between the A and B to form the connection between the A and the B chain. So this sulfur chains will act as the bridge. See here, two sulfur atoms. So this is the structure of the insulin. So next, biosynthesis. It is biosynthesized in the beta cells of the isolates of the Langerhans of the pancreas from pro prepoinsulin. So it is a single characterized precursor and is the primary translation product of the insulin gene. So the insulin consists of 110 amino acids, and first it has to be proceed into the inactive proinsulin and then into the active form of the hormone. So it contains the, see here, it will undergoes the translocation through the membrane of the rough endoplasmic reticulum. So this endopeptidase removes the chain C peptides from the proinsulin. So chain A is the carboxy terminal. It contains 21 amino acids. See here, chain A, carboxy terminal, 21 amino acids. Chain B is amino terminal, 30 amino acids, and chain C is connecting peptide, which contains the 35 amino acids. So proinsulin is exposed to the several specific endopeptides in the endoplasmic reticulum. So it will remove the chain C from the proinsulin and it will generate the bioactive form of the insulin. So I will explain it again. See here, the insulin is which is mainly produced from the pancreas of the beta cells of the isolates of Langerhans. So here it contains the 110 amino acids. So if you see the structure of the proinsulin, what will happen here? Three chains are there. Chain A, B and C. A is the carboxy terminal. It contains the 21 amino acids. And B is the amino terminals. Contains the 30 amino acids. And C is the connecting peptides. So here what will happen? The chain C will be removed in order to get the bioactive form of the insulin. So this is the biosynthesis of the insulin. Next, what is the mechanism of action? So insulin, it mediates its action by on the specific membrane bond and forms on almost of all the body cells. Basically, insulin receptors comprises of two units, that is alpha and beta, which is linked by using the two bisulfate bonds. So binding of the insulin to its alpha subunit, it will stimulate the tyrosine kinase and to activity of the beta subunits. So due to this adjacent beta subunits, it undergoes the phosphorylation process. So along with the phosphorylation of the tyrosine residues of the insulin receptors, which is present on the cytoplasm, this results in the formation of the phosphorylation and dephosphorylation reaction. So the phosphorylation results in the generation of the second messenger like PIP3 and DAG. So this enables the insulin to exert its action on its specific metabolism enzyme. So here what will happen after certain time period, the phosphorylation also activates the various protein kinase, so which mediates the multiplication and differentiation of the several specific cells. So this step is responsible for the formation long-term effect of the insulin. So insulin also causes the translocation of the glucose transporter 4 from the cytoplasm to the cell membrane with the help of ATP. So this transporter helps in take off the glucose by skeletal muscle and the fat cell. So the action of the insulin get terminated when the insulin receptor complex is taken into the cell by endocytosis. So this insulin will be regulated by with the receptor is recycled and translocated to the cell surface. So let's see the pharmacokinetics. So it is a if it is mainly through the parental route of administration. So the oral route of administration is not possible for the insulin intake. So it is best route of administration is subcutaneous, intramuscular and intravenous. So in most commonly we are taking through the subcutaneous route of administration, means that is under the skin. So intramuscular is rarely taken, while the intravenous route is taken but in emergency cases. In most of the emergency cases we are taking the intravenous, but most of the time we are taking through the subcutaneous route of administration, and its off life time is 5 to 9 minutes, and most of the endogenous insulin is 60% is degraded by enzyme insulin in the liver. Certain proportions of the insulin has been metabolized in the kidney and the muscle. The enzymatic degradation of the insulin result in the reduction of the disulfide bonds, due to which the chains get separated. So here what will happen, the chains will get separated because the disulfide bond has been broken, and each of the chain is subjected to form the degradation to constitute amino acid. Means this drug, the insulin is not suitable for the oral route of administration. Mostly it is taken through the parenterally. In the parenteral, mostly it is a subcutaneous route of administration. In emergency cases, we are taking through the intravenous route of administration, and it is metabolized in the kidneys and the muscle. So here what will happen, the enzymatic degradation will be occur. So between chain A, chain B, there will be this sulfur bonds are there. So the sulfur bonds are broken, means automatically the chain will get separated and the chain will get breakdown. Next, insulin preparations. So there are many types of the insulin preparations. Let's see what are there. So conventional insulin preparation induced from the porcine and bovine are not very safe to use because they contain 1% of the non-insulin proteins. Because it is not safe, the conventional insulin preparations are not safe because it contains the non-insulin proteins, so which are antigenic in nature. So it will develop countries. Conventional form has been completely replaced by highly purified recombinant insulin preparation. So if you observe in the many of the developed countries, this conventional preparation of the insulin has been banned. So instead of this conventional preparation of the insulin, the highly purified recombinant insulin preparation are taken. So but in India, this conventional preparation of insulin has been taken because it has a low cost. So let's see the conventional preparation of the insulin. Again, it is subdivided here. See here, soluble or neutral or regular insulin. Next one, insulin zinc suspension. Next one, isofan neutral protamine Hodgdon insulin. Next, protamine zinc insulin suppression. These are the four types which comes under the conventional preparation of insulin, that is soluble or neutral or regular insulin, and insulin zinc suspension, isofan neutral, protamine, Hedron insulin and protamine zinc insulin preparations. Next, highly purified insulin preparation. So this type of the insulin has mostly used in the developed countries. In this, it is divided into the three types, that is highly purified pork regulator insulin, highly purified pork lent, lent insulin, highly purified pork isofen insulin. See, these are the three types, that is highly purified pork regulator insulin, highly purified pork lent insulin, highly purified pork isofen insulin. Next, third one is in human insulins. In this three types, that is human regulator insulin, human lent insulin, human isotope insulin. Next one is human analogs, that is insulin lispro, insulin aspart. Next one is insulin gar gene. So fifth one is insulin gene. So these are the types gene. These are the types of the insulins. That is, see here, first one is conventional preparation of insulin. Next one, highly purified insulin preparation. Third one is human insulin. Fourth one is insulin analogs, and fifth one is insulin glar- glargine. So these are the types of the insulins. Next one, let's see what are the side effects. That is hypoglycemia, local reactions, allergy, obesity, and hepatomegaly, and lipodystrophy. So these are the adverse drug reactions we can see in the insulin. So it is used in the treatment of the diabetes mellitus, and it is used in the treatment of secondary diabetes mellitus, which may occur due to pancreatic disease like pancreatitis, and also the hyperkalemic condition is treated using glucose insulin potassium drip. So these are the uses which comes under the insulin. So up to here we have discussed about the introduction, what are the types of the diabetes and what are the symptoms and what is the insulin and what is its structure and its mechanism of action, what is its uses and adverse drug reactions. Next, let's see what is the oral hypoglycemic agent. So this is the medicine which we are taking through the oral route of administration in order to control the insulin level in our body. So these are the drugs which is used to reduce the blood glucose level, and there are several advantages over insulin. So when we compare with the insulin, this drug has several advantages, like it is effective oral when insulin get degraded in gastrointestinal tract. It has a longer duration of action when we compare with the insulin and its preparation, and it is mainly used in the treatment of the type 2 diabetes when cannot be controlled by diet and exercise. Means the person, those who are regularly doing maintaining the exercise and the diet but cannot able to maintain the insulin level in the body, for that patients, that is type 2 diabetes, for that condition we are using this drug. And also for the age more than 40 years at the onset of disease, and fasting blood sugar that is more than less than 200 mg per dl, obesity condition, disease duration, insulin requirements. Let's see what are classification, means what are the drugs used as a oral hyperglycemia. So here first one is sulfonyl urea. First one is first generation. Example, tolbutamine, chlorpropamide. Second duration is glipinclamide, glipizide, glipipiride, and gliclazide. So these are the drugs which comes under the sulfonyl urea. Next, biguanides. Example, metformin and fenformin. And third one is meg, meg sorry. So next one is meglitinides. Example, rapaglinide and netiglinide. Next, thiazolidones. Example, resiglitazone and piclitazone. Next, alpha glucosidase inhibitors. Example are acarbose and miglitol and viglibose. So these are the drugs which are used as the oral glycemic agents. See here classification, I will explain it again. That is sulfonyl urea. And this first generation is tolbutamine and chlorpropamine. Second generation is glibenclamide and glipizide and glimepiride and gliclazide. So these are the drugs. And biguanines, that is metformin and fenformin, and meglitinides, example rapaglinide and netiglinide. Next one is thiazolinate, examples are resiglitazone and pioglitazone. Next, alpha glucosidase inhibitors. Examples are acrabose and miglitol and viglibose. So these are the drugs which are used as the oral hypoglycemic agent. So let's see what is the sulfonylurea. So these are also known as insulin secretages or chemical related to sulfonamides. But these are the divide of antibacterial agent. So let's see what is the mechanism of action. It has two mechanisms, that is pancreatic action and extra pancreatic action. See here, pancreatic and extra pancreatic action. So here, if we see the pancreatic action, the sulfonylurea will bond to the sulfonyl receptor which is present on the ATP sensitive potassium channels of the beta cells, and it will cause the depolarization of the cell membrane, which leads to the opening of the calcium channel and followed by the calcium influx. So it will increase the intracellular calcium levels, results in the stimulation of the calcium sensitive proteins. So it will promote the release of the insulin, then it will reduces the blood glucose level. So here in the pancreatic action, what will happen means this drug will directly bind it to the sulfonylurea receptors. Here what will happen means it will lead to the opening of the calcium channel. So calcium channel will get open, and which results in the release of the calcium ions. So what will happen here is the stored insulin will be get released. So the insulin will be released and results in the reduce the glucose level. And if you see the extra pancreatic action, so it will also bind to these receptors on the potassium channels in the extra pancreatic cells. So it will increase the insulin receptors on the target cell and particularly on the liver, and it will inhibit the glycolysis and glycogenesis in the liver. So this is the mechanism of action. If you see the SAR, it can be summarized like, see here, certain substituent rings when placed at the para position in the benzene ring leads to the potent activity. Example, if it is replaced with the halogens, amino groups, methyl groups, and methyl thio groups or trifluoromethyl groups. And the size of the terminal nitrogen along with the aliphatic substitution determines the lipophilic property of the molecule. So the optimum activity which results from 3 to 6 carbon atoms. So the nature of the para substitution in the benzene ring, it appears to govern the duration of action. So aliphatic substitution at the terminal nitrogen may also be replaced by the heterocyclic ring. And hypoglycemic activity can be related to the sulfonyl grouping. So replacement of the metabolic easily oxidized by using by like methyl groups by less readily oxidized chlorine was used to transform the short acting tolbutamine into the long acting chlorpropamide with the half life 6 greater than its parent. So this is the SAR. And the pharmacokinetics, so it is a well observed orally. If so, this drug is taken with the oral route of administration, but food interferes with the absorption. So they are highly protein binding. So this is the first generation drug are less protein bound, and it is metabolized in the liver and excreted in the urine. So if the drug is taken through the oral route of administration is well absorbed. But if we see the in case of the glipizide drug, the food will interfere, means this drug should be taken in the empty stomach. So this drug should not be taken with the food, and it is metabolized in the liver and excreted through the urine. And if you see the adverse drug reactions, that is weight gain, hypoglycemia, hypersensitivity, nausea, vomiting, headache. And if you see the uses, it is mainly used in the treatment of the type 2 diabetes, and it is given through the oral route in combination with insulin. So this is the uses.